radioactive iodine 131 has been used for treating thyroid cancer for over 7 years. Now, this is a radioisotope of iodine 127. The difference between iodine 131 and iodine 127 is it has got beta and gamma emitting radioisotope, which is used for cell killing and also for the diagnostic purpose. Now, there is one more isotope which is also used in thyroid is iodine 123. The difference between iodine 123 and iodine 131 is that iodine 123 has got only gamma rays, thus it is used only for diagnostic purpose. It is not used for as it does not have beta rays. Now, coming to the risk of structural disease recurrences in thyroid cancers. As we know, in differentiated thyroid cancer, it is papillary, follicular, and other variants of DTC. Now, to categorize for the recurrence, broadly classified into three groups, which is low, intermediate risk, and high risk, as you can see on the left hand side. Coming to the low risk, where the risk of recurrence is less than 5%, it is seen in patients who have got thyroidal differentiated thyroid carcinoma. In cases of lymph node metastasis, which is less than 5 in number or equivalent to 5 in number in patients with lymph node metastasis, micrometastasis, which is less than 0.2 centimeter. Coming to the second group of risk recurrence, which is intermediate risk. Now, in this group of patients, the risk of recurrence to 30%, seen in patients who have got aggressive histology, which could be tall or hobnail or a columnar variant, and patients with a minor extrathyroidal extension, T3 group patients, vascular invasion, patients who have more than five involved lymph nodes, but the size of the lymph nodes are less than 3%. The highest one with recurrence is the high risk. Now, these patients are the patients who have got gross extrathyroidal extension or have had incomplete tumor resection, patient presenting with distance metastasis or lymph node which are of more than 3 centimeters. So, if we can see, the risk of recurrence can go up to 55%. Now, this is ATA 2009 risk stratification system with proposed modification, which was given in the year 2015. In the ATA low risk, this is initial risk stratification. For papillary thyroid cancer, it is when the patient does not have local or distant mets, all the macroscopic tumor has been resected, there is no invasion loco-regionally or other structures, no aggressive histology, and in case if iodine 131 scan has been done, there is no metastatic foci outside of the thyroid bed. There is no vascular invasion, and if in case there is clinically N0, it is or if in case the lymph node is present, which is less than number of 5 or equivalent to 5 in with micrometastasis of 0.2 centimeter in the largest dimension. That was about papillary thyroid cancer. Now, in case of a follicular variant, if it is intrathyroidal or encapsulated, in case of follicular thyroid cancer, if it has got capsular invasion or vascular invasion with foci less than 4. In case of papillary microcarcinoma, unifocal or multifocal, if it is intrathyroidal with BRAF mutation positive. Now, AT intermediate risk. Microscopic invasion of the tumor if it is present perithyroid. If there is RAI avid metastatic foci in the neck of the first post treatment following surgery, there is aggressive histology, papillary thyroid cancer with presenting with vascular invasion, clinically N1 or more than 5 pathologic lymph nodes with size less than 3 centimeter, multifocal papillary microcarcinoma with extrathyroidal extension and BRAF mutation present. Coming to ATA high risk. Now, in ATA high risk, macroscopic invasion of tumor into the perithyroidal soft tissue. That means if there is gross extrathyroidal extension present, if there was incomplete tumor resection for any reason, distance metastasis, post-operative serum thyroglobulin is raised, suggesting of distant metastasis, pathologic N1 with any metastatic lymph node more than 3 centimeter in the largest dimension, or a follicular thyroid cancer with extensive vascular invasion of foci more than 4. Now, after total thyroidectomy, NED is no evidence of disease if it is thyroglobulin stimulated is less than 1 nanogram per ml without any radiologic or clinical evidence of disease. So again, it is divided into three groups. Low risk patients, they have around 78 to 91% will have no evidence of disease. Intermediate risk of about 52 to 64% of no evidence of disease, and high risk of about 31 to 32% no evidence of disease. Coming to the risk of recurrence in papillary carcinomas, in unifocal, it is about 1 to 2% risk of recurrence. Multifocal, it's about 4 to 6%. In intrathyroidal papillary thyroid cancer, it is 5 to 6%. In intrathyroidal papillary thyroid carcinoma, which is more than 4 centimeter, the risk of recurrence is about 8 to 10%. When we are talking about the lymph nodes, if the lymph node involvement is 5 or less, the risk of recurrence is 4%. If there is micrometastasis, it's about 5%. If more than 5 lymph nodes are involved, the risk of recurrence is 19%. More lymph nodes is about 21%. And if macroscopically, clinically evident nodes, it's about 22%. In metastasis, which is more than 3 centimeter, it's about 27%. Talking extrathyroidal extension, minor extrathyroidal extension is about 3 to 9%, and if involved, it is about 20 to 40%. Follicular thyroid cancer, if it is well differentiated with only capsular invasion, the risk of recurrence is up to 7%. If it is with minor vascular invasion, only confined to the intracapsular vessels, the risk of recurrence is about 0 to 5%. Whereas when the vascular invasion is present, then the risk of development of new identified distant metastasis rises up to 30 to 55%. Now, it has BRAF mutation or no BRAF mutation. What is the lymph node metastasis difference that we see is in BRAF mutation patient, it's about 11.1% compared to 2.6 in no BRAF mutation. It is significant statistically. Distant metastasis is seen more in BRAF mutation, about more than 50%, 51% it is, with significant p-value. Age more than 45% will have more of BRAF mutation, just about 8% compared to 1.9 without BRAF mutation, again statistically significant. When we see the recurrence rate in BRAF mutation and non-mutation patients, it is highly statistically significant, with a recurrence between 11 to 40% in BRAF mutation. Now, after surgery, we have to evaluate the patient and do follow-up. So the follow-up evaluations is done using ultrasound neck, RAI scan, serum thyroglobulin, antithyroglobulin, dynamic risk stratification. Now, what is dynamic risk stratification? As we all know, the initial staging system helps us to guide in the therapeutic and early diagnostic follow-up strategy decisions. So, what is dynamic risk stratification? For any individual, it depends on its individual response to therapy in the real time during their follow-up, and these modifies their initial risk and then estimates in an ongoing or dynamic process. It is a response. Second is biochemical incomplete response. Third is structural incomplete response. And fourth is indeterminate response. Now, what is excellent response? If we define it is uh, intimates that no formulated thyroglobulin is less than 1 nanogram per ml, or the unstimulated thyroglobulin is less than zero point 0.2 nanogram per ml. So clinically, the risk of recurrence in these patients is about 1 to 4%, and the disease specific death is less than 1%. So, how it affects the management? We can decrease the intensity and frequency of follow up of these group of patients, and also can decrease the degree of THZ suppression in this, which is about zero point 0.5 to 2 milliunits per liter. Where do we see this excellent response to initial therapy? It is mainly seen in ATA low 86 to 91 patients. In ATA intermediate, again, a high number of patients are there, which is about 57 to 63% of patient. Whereas in ATA high risk patient, it is very low, which is about 14 to 16% only present with excellent response. Coming to the biochemical incomplete response. So, what is it? In this, again, there is no imaging, there is nothing, no uptake on imaging or in ultrasound. The stimulated thyroglobulin is more than 10 nanogram per ml, along with thyroglobulin is again more than 1 nanogram per ml. So what happens in these patients? 30% of these patients will have no evidence of disease spontaneously. 20% of these patients will require additional therapy, and then there will be no evidence of disease. Where patient percent of patient will develop structural disease in these group of patients. Specific death rate is just less than 1%. So we manage these patients. If the patient has stable or declining serum thyroglobulin, we'll observe this group of patients. However, if these patients have rising thyroglobulin or anti-TG, then we will go for additional investigations therapies. So it is mainly seen in uh, ATA low risk patient, mainly seen in it is equally divided in all three groups, which is 11 to 19% in low risk, 21 to 22% in intermediate risk, and 16% in high risk. Coming to the structural incomplete response. If there is a disease structurally or functionally evident, then it is structurally incomplete response with any thyroglobulin report, with or without anti-TG antibodies. So, how they clinically present? About 50 to 85% will have persistent disease. When we see the disease specific rate in them, loco regional, it's about 11% death rate, and with distant metastasis, it's about 50%. Management includes additional treatment, ongoing observation. So, the highest number of patients which is seen in structurally incomplete response belongs to the ATA high risk, which is 67 to 75%. And in intermediate risk patient, it is about 19 to 28%, with the least in low risk patient, which is about 2 to 6%. And in this group of patient, we should keep the TSH suppression below 0.1 milliunit per liter. The last group is indeterminate response group. So what is this? In this, there is non-specific findings, which can be either a avascular thyroid nodule, or they can be atypical cervical nodes present. And it can also be faint uptake on RAI scanning. However, the stimulated thyroglobulin is less than 10 nanogram per ml. Unstimulated thyroglobulin is less than 1 nanogram per ml. And anti-TG antibody is either stable or declining. So, in follow up, what do we see is 15 to 20% of these patients will develop structural disease, or either they will have stable or resolving non specific changes, which is seen in also a good number of patients. Seeing the death specific rate again is less, which is less than 1%. How to manage these patients? Keep them under observation, keep doing serial imaging, and have a serum TG monitoring a repeated at least a 6 to 12 months of interval. The TSH suppression in these group of patients should be zero point 0.1 to zero point 0.5 millionits per liter. Now coming to the clinical decision making. This is the low group of patient. If we have a low group of patient in which we have only done total thyroidectomy, so how will we evaluate? First thing is we will see serum thyroglobulin at 3 or 4 weeks post-operatively. We can go ahead with post-operative diagnostic scans or ultrasound may be considered. When it comes to RAI remnant ablation, it is actually not recommended. And if it is done, we can give 30 millicurie favored over the higher administered activities. Now, to maintain the TSH in them, in it should be around 0.5 to 2 milliunits per liter, and the non-stimulated TG value should be less than zero point 0.2 ng per ml in excellent response, and in indeterminate and incomplete response, it is more than zero point 0.2 ng per ml. In those patients, we should maintain the TSH at zero point 0.1 to zero point 0.5 milliunits per liter. Now, for evaluation, we should do thyroglobulin testing, which can be done at 12 to 24 months interval, and neck ultrasound. We can do diagnostic whole body scan with iodine 131 is not routinely recommended. Now, next is if patient has underwent lobectomy. Again, the post-op evaluation remains the same. Again, RAI remnant ablation is not recommended in these group of patient. We have to maintain initial TSH at zero point 0.5 to 2 milliunits per liter. For evaluation, it is neck ultrasonography and thyroglobulin testing at 12 to 24 months interval. Coming to ATA intermediate risk differentiated thyroid cancer patients. These group of patients who have underwent total thyroidectomy with clinical N1 disease, therapeutic neck dissection is done, plus minus prophylactic central neck dissection. The evaluation remains the same, and for ablation, 30 millicurie is generally favored. And if we are giving adjuvant ablation, the dose is up to 150 millicurie. This group of patient, the TSH level which we have to maintain is 0.1 to 0.5 milliunit per liter. For evaluation, thyroglobulin testing, neck ultrasound, and we can consider for whole body radioactive iodine scan at an interval of 12 to 24 months. Now, this is the high risk patients. So, the evaluation remains the same. In this, the RAI has to be considered of adjuvant, which is up to 150 millicurie. And if there is any structural disease which is present, we have to consider dose of 100 to 200 MCI. In case if the patient has any renal insufficiency, we have to decrease the dose up to 100 to 150 MCI. The initial TSH goal we have to maintain should be less than 0.1 milliunit per liter. Now, how to evaluate the response? We have to do thyroglobulin test, neck ultrasound. We should consider for CT MRI or FDG PET diagnostic whole body scan. The interval here is coming to decision making for RAI therapy. What are the decisions which we should consider? First is post-operative status. This is one independent predictor of persistent or recurrent disease. So it plays a very important role. Second is post-operative serum thyroglobulin. In patients who have got serum thyroglobulin of 20 to 30, optimal sensitivity and specificity says that there is definitely a persistent disease or recurrence. The next is post-operative diagnostic RAI whole body scan. So there are two radioisotopes which we can use. The dose we have to keep is low for iodine 123, 1.5 to 3 millicurie. And for iodine 131, again 1 to 3 MCI. Now, the advantage of this is we can accurately see the remnant and the residual disease present. The next is the single positron emission computed tomography or the CT scan. The advantage of this is we can have identification and isolation of the foci of the disease, and it also aids in more confirmation of the radioactive iodine scan. Now, the post-operative radioactive iodine planar imaging has been reported to yield information which could alter our clinical management in up to 25 to 53% of the patient. So, what is the dose that we have to keep and why we have to keep it low? There's something called as stunning phenomenon, which is post this dose, there is inflammation which is seen of the tissues. So, it is mitigated and avoided by using either low activity iodine. There is also a controversy of doing a pre-therapy scan. Now, what are the goal of RAI administration? First is permanent ablation. This does not have any role in the disease specific survival or disease free survival. This is basically, it destroys the thyroid tissue, which helps to optimize the thyroglobulin measurements and also aids in whole body radioactive scans post operatively or in the follow. Now, next is the RAI adjuvant therapy. The main is to improve the disease free survival, the progression free survival by identifying suspected microscopic foci but unproven residual disease, especially in patients who are at risk of disease recurrence. Now, next is RAI therapy. This is intended to improve the disease specific and disease free survival, progression free survival by treating the persistent disease patients who are at higher risk. An additional consideration in RAI has to be given in patient with comorbidities with who has got renal insufficiency. Coming to RAI remnant ablation. For low risk, it is not recommended. For unifocal papillary microcarcinoma, after lobectomy or total thyroidectomy, it is not recommended. For multifocal papillary microcarcinoma, in absence of other adverse features, it is not recommended. In ATA, intermediate risk level of differentiated thyroid, it, following total thyroidectomy, it is recommended. In high risk patients, following total thyroidectomy, it is routinely recommended. Now, this is a table which shows the risk of the patient along with the TNM staging. So, ATA low risk patient with ATA low risk patient with T1A, where the size of the tumor is less than or equivalent to 1 centimeter. There is no body of RAI improves the disease specific survival or the disease free survival. Thus, there is no indication of RAI in. Sorry. In case of ATA low risk cases of T1A, T2, M0, M0, where the tumor size is more than 1 centimeter or less than 4 centimeter. Again, there is no body of evidence which suggests it improves the disease specific survival. However, this conflicting observational data shows that RAI improves the disease free survival. Thus, it is not routinely recommended, but it can be recommended in patients who have got aggressive histology or have vascular invasion. Now, in case of ATA, a low to intermediate risk, a T3 group of patient without microscopic extra, the tumor size is more than 4 centimeter. There is conflicting that radioactive iodine needs the disease specific survival and conflicting observational data that RAI improves the disease free survival. In these group of patient, we should consider or in case of presence of other adverse features, if the age is more than 55 years, previously the age 45 years, now it has been changed to 55 years. It should be considered female patients. Next is 8 low to intermediate risk in T3 with microscopic extrathyroidal extension with any T size. There is no evidence that RAI improves disease specific survival and conflict observational data is there. that showing that RAI survival. In these group of patient, it is considered based on the risk of recurrence in these patients. However, if the tumor is small with microscopic extrathyroidal extension, they might not require RAI. Next is low to intermediate risk T1 to T3 N1, where the central compartment neck lymph node metastasis. So there is no as such body of evidence which suggests, however, there is possibility in patients who are more than 45 years of age. In case of disease free survival, there is conflicting observational data. We should consider giving RAI in these group of patients, considering there is a high risk of persistent disease and there is lymph node positivity, extranodal extension, and age. Next is in patients ATA low to intermediate risk T1 to T3 with lateral neck node or mediastinal lymph node metastasis. Again, it is same as the central compartment group of lymph nodes. Next is high risk patients with T4 with gross extra thyroidal extension or any group of patient with distance metastasis. There is definite body of evidence suggesting that RAI improves the disease specific survival and disease free survival. So post surgical RAI is definitely indicated in these group of patients. Again, if there is ATA low risk, the disease specific mortality is low. The risk of persistent and recurrent disease is low, which is about 3%. There is no as such reports showing that there is a disease specific or disease free survival improvement. There is little evidence which suggests RAI may improve disease specific mortality, and there is conflicting evidence which is its effect on recurrence with newer data using the air ATA risk system suggesting the lack of significant effect. There is one trial which was a Hilo trial where they had included 434 patients. Now, in this study, they had enrolled only low risk and intermediate risk differentiated thyroid cancer patients. They used low risk as it was associated with lower rate of adverse events than the high dose. It required shorter hospital isolation and the cost was comparatively lower. Now, the number of patients were divided into two broadly groups, which was subdivided into two groups again. There were a high dose group and low dose group. So 1.1 becquerel, which is 30 millicurie in the low dose group, and 3.7 or 100 millicurie in the high dose group. So again, what they also analyzed in this study was they also evaluated the outcomes in thyroid hormone withdrawal group and patients who were on recombinant TSH group. What they noted was in the recombinant thyroid stimulating hormone group, the recurrences in the low dose group was 8, whereas in the withdrawal it was only 3, whereas 5 recurrences was noted in groups in the high dose group. When we compared both the groups of low dose and high dose, the recurrences was fairly nearly same, which was 11 recurrence in the low dose group and 10 recurrence in the high dose group. Now, what they also saw in the intermediate risk patient, the recurrences were more in low dose group, which was not statistically significant. Low risk patient was had recurrences more again in the low dose group, and however the recurrences was more in high dose group when recombinant TSH was used. However, it was not statistically significant when it was compared between different histology. It was not different between both the groups, and it was not statistically significant. Most of the recurrences were noted between 3 to 8 years, and majority of them were below 5 years. If we see in the graph also, between the high dose and the dose group, it was overlapping with non-significant in high dose and low dose group, and in the thyroid hormone withdrawal and recombinant TSH group early years. Now, they found that low dose group had similar ablation success rate in the low and intermediate risk group patients. Comprehensive and definitive evidence was there that showed that radioactive iodine is an acceptable therapy for patients with differentiated thyroid cancer. This also provided evidence further to support the use of recombinant TSH in low dose radioactive iodine group. There was one more study which was done between 2007 2010, which was STEMABL 1, which was done in 726 patients. It was a phase 3 clinical trial where they had evaluated patients for a follow-up of 5.4 years between the low dose and the high dose group, and they found there was no difference in the recurrence risk between both the groups. Now, this is another phase 3 clinical trial which was done in low risk differentiated thyroid cancer. That this was STAMABL2 phase 3 clinical trial, which was done in 2012 and it was published in the year 2022. In this, 730 patients were included in the study and were followed up for 3 years. The aim was to improve RAI in the low risk differentiated thyroid patients. So, what they did, they were divided into two groups. In the first group, there was a low dose, which was 30 millicurie, along with recombinant TSH was used, whereas there was no RAI given. When they compared the response rate at the follow-up after the follow-up 3 years, it was 2% in no RAI group, and in RAI group, it was 2%. Non-inferiority RAI was confirmed. Now, interest. In which patient does it improve the overall survival? If the patient has histologies like tall cell diffusing sclerosing or insular variant, it has better overall survival if we give RAI. Who had node positive adult patient with papillary thyroid carcinoma who were more than 45 years, with a median follow-up of about 6 to 8 years, they found that 99% of the patients were alive. Also, in patients with pathologically T3 microscopic extrathyroidal extension, node negative papillary thyroid cancer patients with the age less than 45 years, 98% of the patients were alive. Now, if we see those patients who were more than 65 years, we see that with RAI or without RAI, their overall survival was less. With RAI, it was 73%, and without RAI, it was 69%. So, benefits of giving adjuvant RAI in these intermediate risk patient improves overall survival, disease-free survival, disease-specific survival with nodal metastasis age who are more than 45 years, as per the National Thyroid Cancer Treatment Cooperative Study Group, in patients who had adverse thyroid cancer histologies. In patient there, if there is increased volume of nodal disease, lymph node disease outside the central neck, and in patients who are more than 55 years, 50 more than 45 years of age. Coming to AD high risk, routinely it is recommended in high risk patients. Now, there was one cancer uh, uh, study that was data was seen, that was by the systematic epidemiology end result cancer registry, which suggested that in patients with PTC with distant metastasis more than 45 years, tumor size was more. With positive lymph nodes at the primary diagnosis, the overall survival was better. It also suggested that in patients who had follicular thyroid cancer with distant metastasis who received post surgical RAI, their more than 2 times. Now, there is not significant data on whether RAI works on these group of patients. This be it still needs to be done, and the results are yet to be established. Now, what is seen is that in patients who have got BRAF mutation, there is significant reduction in the sodium iodine symporter expression, and thus it also decreases the radioactive iodine uptake. However, there are studies yet to be done to confirm this. Now, in patients whom we are giving whether diagnostic RAI or therapeutic RAI, we have to withdraw the thyroid hormone. So, when should we do it? Ideally, if we are giving LT4 or the levothyroxine, it should be withdrawn 3 to 4 weeks earlier. Or if in case if there is we cannot keep the patient on with hypothyroidism for long, we can convert or shift from levothyroxine to levothyronine. For 2 weeks we can keep levothyronine, and then just 2 weeks prior to the diagnostic or therapeutic activities we can withdraw. Coming to the recombinant TSH stimulation, it can be given in low risk and intermediate ATI risk patients without extensive lymph node involvement. The advantage of this is it has got superior short term quality of life, non inferiority of the remnant ablation, proven efficacy, no significant difference in the long term outcome. However, in high risk patient, we need more control data from long term outcome studies. So, when we see its indication, it is mainly indicated in medical or psychiatric patient that could be acutely exacerbated with hypothyroidism and can lead to serious adverse events. In patients who have inability to mount an adequate endogenous TSH response with thyroid hormone withdrawal, in those patients also recombinant TSH can be used. Now, the dose of iodine 131. For a low risk or intermediate risk with lower risk features, 30 MCI can be used. There was one study who reported that 100 MCI is superior, which was by Falahi et al. In for successful remnant ablation after thyroid hormone withdrawal. However, other than that, there was another study which was opposite to it, which was by Pili et al., who reported that the administered activity of 50 MCI was found to be not inferior to 100 MCI in achieving successful remnant ablation following the preparation with recombinant TSH. This was another study which was by Castagna et al., which found that we can use 30 to 50 MCI and it has got comparable result when patients were given more than 100 MCI of adjuvant RAI. There was no significant difference in the rates of successful remnant ablation in long term disease persistent or recurrence between the two groups. Now, the patients who are undergoing remnant ablation, we should consider and give them low iodine diet at least 1 to 2 weeks prior before they go for RAI remnant ablation or treatment. How it works, this actually reduces the presence of excess stable iodine in the body and thus helps the radioactive iodine uptake in the thyroid cells. So the daily intake should be reduced less than 50 microgram per day, and the patients who are undergoing therapeutic activities, they should avoid intravenous contrast studies 3 weeks prior undergoing RAI studies, or any patient who are taking foods or drugs containing iodine such as amiodarone, betadine or Lugol's iodine needs to be avoided. So coming to the follow-up, a post-therapy whole body scan is recommended after RAI remnant ablation or treatment. This is basically to inform the disease staging and also document the RAI avidity of any structural disease. So if we are doing RAI, the sensitivity is about 78% with specificity of 100%. The if we add SPECT or CT along with it, It alters the post-surgical ATA recurrence rate estimation in about 6.4%. Post RAI, how much dose should we keep? For high risk patient, we should keep it below zero point 0.1 milliunits per liter. People have also tried giving lesser dose. However, it does not offer any benefit if it is less than 0.03. In intermediate risk patients, we should keep it above 0.2 milliunits per liter. In low risk, if it is undetectable, we can keep the TSH to 0.5 to 2 millionunits per liter. When no, it has low serum thyroglobulin, we have to keep it zero point 0.1 to zero point 0.5 millionits per liter. And for low risk patient, again, as mentioned, it is 0.5 to 2 millionits per liter. Most of the patient can maintain in this range. If they cannot, they should be given thyroid hormone therapy. So long-term effects of TSH suppression. These are the consequences of the subclinical thyroid toxicosis, which we'll see in these group of patients. They present with increased risk of atrial fibrillation. In postmenopausal women, there will be increased risk of osteoporosis. In ischemic heart disease patient, exacerbation of angina could be seen. Coming to the role of serum thyroglobulin measurements in the follow-up patients. So, what we see is if there is 1 gram of neoplastic thyroid tissue, there will be increased serum thyroglobulin by 1 nanogram per ml during the levothyroxine treatment. And if we do TSH stimulation, then it increases by 2 to 10 nanogram per ml. So this is a very important thing. If we have a raised thyroglobulin, we should consider or we should suspect persistent disease or recurrence. Now, when we are doing serum thyroglobulin, we should do it along the anti-TG or antibodies. They should be assessed longitudinally and mostly it should be done from the same laboratory. Now, when should we measure? It should be done every 3 to 12 months. In case of low and intermediate risk patient, it can be lengthened to 12 to 24 months. So, serum TSH should be measured at least 12 months in all patients on thyroid hormone therapy. So post-operative thyroglobulin greater than 5 to 10 ng per ml increases the likelihood of identifying RAI, avid metastatic disease on the post-therapy scan. Post-operative thyroid hormone withdrawal stimulated TG level more than 5 to 6 ng are associated with higher rates of failed ablation after administration of both 30 to 100 MCI. If the stimulated thyroglobulin is more than 6 nanogram per ml, it was associated with 5-fold greater risk of failing ablation after an activity when 30 MCI was administered. And when the thyroglobulin values are greater than 10 to 30, it has the likelihood of having persistent or recurrent disease, as mentioned, failing the initial RA ablation, having distant metastasis, or dying of thyroid cancer. Post-operative TG values more than 10 ng per ml. Additional evaluation should be done. Additional therapies are recommended. Now, what is anti-TG thyroid cancer patient and in 10% of the general population? It should be done in conjugation with serum thyroglobulin. It can rise transiently post-operative or after patient also, which is because of the immune reaction which occurs. Now, in case of recurrent or progressive disease, initial patient will have anti-TG antibodies positive, then it will become negative, and then if it rise, you should suspect recurrent or progressive disease in these group of patient. If the anti-TG antibody is falling, then it indicates that there is successful therapy. Now, from clinical perspective, how anti-TG works is if they're declining over time, it is considered to be a very good prognostic sign. While rising antibody without any absence of surgery or RAI treatment, we should consider that the patient has either persistent or recurrent thyroid cancer. Now, diagnostic whole body scan during follow-up. In low risk or intermediate risk patients, when it is undetectable, negative anti-TG antibodies. We do not require diagnostic whole body scan in case of high or intermediate risk of persistence disease. uh, then in those patients we should do RAI scan after withdrawal of thyroid hormone or recombinant TSH as 6 to 12 months after adjuvant RAI therapy. For if a patient has loco-regional or metastasis, how should we treat them? There are basically three methods. First is we can give empiric fixed amounts, or we have therapy determined by the upper limit of blood or blood dosimetry, or quantitative tumor or regional dosimetry can be used. So, in distant meds, the efficacy of RAI is related to the mean radiation dose, which is delivered to the neoplastic foci, and it also depends on the radiosensitivity of the tumor tissues. It is usually higher in patients who are younger with smaller metastasis, who have got radioactive iodine uptake and no or low FDG uptake. Now, maximum tolerated radiation absorbed dose. What is this? So, the dose is commonly defined as 200 radiations rats to the blood, and it's potentially exceeded in significant number of patients undergoing empiric treatment with various amounts of iodine 131. For example, if the patient is of a group of patients who are more than 70 years of age and 250 MCI is given, in those group of patient, the maximum tolerated radiation absorbed dose is more than 50% in patients who are above 70 years, and compared to patients who are less than 70 years, it is about 22%. So this was like an example. So we should be cautious in administering empiric activities higher than 100 to 150 MCI in certain populations such as elderly patients or patients with renal insufficiency. Now, if a patient has brain metastasis, MRI of brain and spine is recommended, and in those patients, we should institute high dose corticosteroid therapy to limit the risk of acute tumor swelling and compromised functions. Dexamethasone in a low dose of 2 to 4 mg every 8 hours, starting 6 to 12 hours prior to recombinant TSH, and RAI dosing, or after 10 to 12 days of thyroid hormone withdrawal is given. We should continue the steroids in tapering dose for 1 week post therapy for 48 to 72 hours in after recombinant thyroid stimulating hormone administration, or for 72 hours after reinstitution of thyroxine therapy. The best treatment would be surgical resection or stereotactic EBRT. Fewer data shows the efficacy of RAI. Now, pulmonary metastasis, uh, RAI therapy should be given, every 6 to 12 months, as long as the disease continue to respond and concentrate RAI. Highest rate of complete remission has been reported in these subgroups. So the dose will be for pulmonary micrometastasis. It can be 100 to 200 MCI for a normal group of patients, and if the patient is more than 70 years, 100 to 150 MCI. If the dose is estimated by dosimetry, then it should be limited whole body retention to 80 MCI at 48 hours and 200 centigrade to the bone marrow. In cases of macronodular metastasis, again it is 100 to 200 MCI, lesional dosimetry or whole body dosimetry if available, in order to limit the whole body retention to 80 MCI at 48 hours or 200 centigrade to the bone marrow. Now, the rare complications which are seen are the pulmonary pneumonitis and fibrosis. Bone metastasis, if it is RAI avid, then it can be used to a empirical dose of 100 MCI, or it is determined by dosimetry. RAI is rarely curative in cases of bone metastasis. Now, there is one more thing about use of lithium. However, there is no outcome data which demonstrate better outcome in these group of patients who have lithium along with iodine therapy given. The role of lithium, it inhibits the iodine release from the thyroid, without impairing the iodine uptake. Thus, it enhances the iodine 131 retention in the normal thyroid and tumor cells. There was a study which found that the lithium increased the estimated iodine 131 radiation dose in metastatic tumors on an average by more than two folds, but primarily in those tumors which rapidly cleared iodine. On the other hand, there was one study which was unable to document any clinical advantage of lithium therapy on the outcome of the patients with metastatic disease, despite there was an increase in the RA uptake in the tumor deposits. However, the data is insufficient. Coming to the adverse effects of RAI: nausea, gastric discomfort, xerostomia, silidinitis, lacrimal outflow obstruction, epiphora, bone marrow suppressions, and secondary malignancies also seen post RAI. The risk of secondary malignancies is again dose related, which is for solid cancer, the absolute risk is about 14.4, point 0.8 for point 0.8 for leukemias per 1 g per ml. Cumulative dose over 500 to 600 MCI are associated with significant increase in the risk. Coming to the pregnancy, breastfeeding, and gonadal functions, it should patient should have a negative screening evaluation for pregnancy prior administration, and avoid pregnancy at least for 6 to 12 months after receiving RAI. For nursing women, RAI should not be given. Depending on the clinical situation, RAI therapy could be deferred until lactating woman has stopped breastfeeding or pumping for at least 3 months. Men receiving cumulative RAI activities more than 400 MCI should be counseled for potential risk of infertility, and sperm banking should be considered in these group of patients and in pediatric children. RAI refractory differentiated thyroid cancers. Now, this is the last part of the topic. Appropriate TSH stimulation and iodine preparation when done, it can be RAI refractory can be classified into four broadly groups. The first is when the malignant and metastatic tissues does not concentrate RAI. The second is the tumor tissues loses the ability to concentrate RAI after previous evidence of RAI avid disease. The third is RAI is concentrated in some lesions but not in others. Fourth is metastatic disease progresses despite significant concentration of RAI. So, when the patient is RAI refractory, there is no indication of further RAI. Coming to the conclusion, one should have a clear understanding of the dynamic risk stratification for improving the disease specific, disease free, and overall survival of the patient. Thyroid stimulating hormone, thyroglobulin, are important for evaluating of the disease. RAI is mandatory in high risk patients, and for low and intermediate group of patients, it depends on initial stratification, and thus the patient should be taken for remnant. These are the list of references. Thank you.
Uh, Thank you, Dr. Ka, for that extensive research on RAI therapy. Uh, mm, uh, Ravishwa sir,
Yeah, hello.
so I think
So, yeah, that was an
you
excellent talk
can
by.
take over and summarize the things,
Yes, yes,
and we can take any questions.
yes. So I'll just summarize briefly. First of
Yes,
all,
sir.
let me congratulate Dr. Shikha. She had a beautiful presentation, very extensive. Nothing left for chance. Everything was covered beautifully.
Thank you, sir.
Now, yeah, now I have only I have made some points to be fine-tuned. Like iodine 123 is not available in India. So in India, we are doing iodine 131 as well as therapy with iodine 131, right?
Yes.
Am I clear now?
Yes.
Yes, sir.
Am
Yes,
I
sir.
audible to everyone? Yeah, okay. Thank you. Similarly, what we are doing is a dynamic risk stratification That is done even after post-op status. Like the emphasis of the talk was about dynamic risk stratification for giving radioiodine therapy. That is not really so. It is even for post-operative status, you are doing dynamic risk status stratification. For example, see if you have um, 1 centimeter intrathyroidal lesion with no extracapsular extension, but with post-op histopathology showing more than four foci of vascular invasion, it becomes intermediate risk, right?
Yes,
Yes,
sir.
sir.
So dynamic risk stratification is not only for radioiodine therapy, it is also for post-operative stratification. Second is Dr. Shikha has aptly pointed out importance of anti-TGI antibody. So for every patient with TG, we should get anti-TG antibody. In the background of Bihar, I can confidently say if you write serum TG levels, they give you instead of thyroglobulin, they give you triglyceride values. So I advise everyone to write completely thyroglobulin levels. Okay, that is one practical problem that we have faced here in Bihar. Next
Yes.
is regarding recombinant TSH. So, recombinant TSH protocol, everything was correct what she told me. There is some practical problem like the entire therapy of radioiodine will cost you around 80,000 to 1 lakh rupees for 100 millicuries, right?
Yes,
This RTSH itself is around 85,000 rupees. So
Mm.
yes,
in a state with very poor per capita income, patients are will be financially heavily burdened, and most of the patients refuse treatment even for 2,000, 5,000 rupees. So this aspect we have to see. Even at big government institutes like PGI Chandigarh, they are unable to use RTSH. Okay.
Mm. Yes, sir.
Now coming to HILO trial. HILO trial was like um it gave us excellent values of using 30 millicuries for intermediate risk and low risk cases selectively, right?
yes, yes,
Uh, and their follow-up was for around less than 5 years. So in 2019 or 20, if I am correct, Dr. Sikha can correct me if I'm wrong. 2019 or 20, follow-up came for that HILO trial.
yes,
And there was a very interesting finding that in patients who were given 30 millicuries radioiodine, the incidence of distant mets was significantly more compared to patients who were given 100 millicuries upfront. And those patients, and 10% of those patients had to be treated with the high dose radioiodine 100 millicuries at a later date. So this data is not widely available with people, right? I
Yes,
am
sir.
not
yes,
saying that everybody should be given 30 millicuries. What we are practicing is like when you are doing remnant ablation 30 millicuries, there is a rule of thumb that we are following in India. So
Mm.
if you are low risk and very low uptake in thyroid and all other blood tests, okay. So we are not giving like uptake, the thyroidal bed uptake less than 0.2%, TG and less than 2, and low risk patient, we are not giving any radioiodine ablation. But even in low risk patients with the uptake value more than 0.2% and with some post-operative findings which are pulling it into intermediate risk, we are giving anything between 30 to 50 millicuries for localized operative failure. If we are able to see neck notes on radioiodine scan, we give around 50 to 100 millicuries. If
okay,
pulmonary mets are there, around 150 millicurie, and if bone mets are there, 200 to
Mm.
250 millicuries per sitting.
yes,
Okay.
yes,
Another point I wanted to make was for radioiodine refractory therapy.
Yeah.
So even there is another criteria, not widely publicized, is like if you have given more than 300 millicuries of radioiodine and
Yes.
you still have residual disease, then you should consider it as radioiodine
So one
refractory
second,
disease.
sir. 1 second, sir. Dr.
Okay.
Sanap, please mute yourself.
9766811913.
Uh,
1913.
Dr. Sanap, Dr. Sanap, please mute yourself. Yeah, thank you. Sir, please,
Okay.
sir.
So where was I? I'm sorry, I
Sir,
got
refractory
disconnected.
RAI, sir,
Yeah, yeah.
that we
So
still.
even if you have given 600 millicuries
Yes,
and there is residual disease,
yes,
even though it is radioiodine avid, it will be considered radioiodine refractory
Refractory.
this thing. Okay.
yes,
And last but not the least, about whole body iodine scan and post-therapy iodine scan, right? There are two words that we are using:
yes,
diagnostic whole body iodine scan and post-therapy iodine scan,
yes,
right?
sir.
So
Yes, sir.
diagnostic whole body iodine scan is what we are doing pre-therapy.
Pre-therapy, yes.
Routinely for all patients who have received high dose radioiodine therapy, 3 to 5 days post therapy, we are doing post therapy scan. The idea is the sensitivity of iodine scan in the amount of iodine that we give. In pre-therapy scan, we cannot give higher doses because of stunning. So we are limited to 1 to 3 millicuries.
Yes, sir.
So its sensitivity is not compared to post-therapy scan, where we have given full dose. And that is why in a significant number, up to around 15 to 20% cases, post-therapy iodine scan sometimes throws up surprise in form of previously undetected metastatic disease.
Mm.
Okay.
Yes, sir.
Yes, sir.
Okay. Now, if anybody is interested in asking any questions, I'm open to take questions. Or if anybody has any confusion, kindly ask.
Sir, one
Sir,
confusion, sir.
Yeah.
Sir, so that as per you, you mean to say we don't give diagnostic up any this drug. Whatever we give, that is therapeutic. That we can later on that becomes as diagnostic also.
No. I will repeat again what I was saying. Okay.
Okay, sir. Mhm.
So, what is the role of diagnostic whole body iodine? So, because you are not doing like metastatic workup is not possible in pre-surgery. It is only possible once thyroid has been taken out,
yes, yes,
right? In up to 25 to 35 cases, diagnostic iodine scan detects some distant metastasis, right?
yes,
What I am saying is that is up to 25 to 30% cases of diagnostic scans. After that, you have found that you have to give radioiodine, you have given radioiodine therapy. Post radioiodine therapy at the time of discharge, which is after discharge, around 3 to 5 days after scan, after therapy, we do another scan where not giving any diagnostic doses of radioiodine. We have already given therapeutic doses of radioiodine, and based on that, we have done a scan at 3 to 5 days.
Mm.
And as the dose of radioiodine was higher, the chances of occult metastasis being found out are higher.
Right.
So even post-therapy scan gives additional benefit of 15 to 20% of cases being detected post-therapy of metastasis. Okay, so my whole point was don't get confused between post-therapy scan and diagnostic whole body scan. Both are different, both have different roles.
sir,
Again,
having said that, sir, do we really need a pre-therapy scan, sir? Or should we go ahead with therapeutic dose, sir? Like,
Excellent.
there is a
Excellent,
controversy.
excellent.
Yes,
So there are two approaches to therapy. I saw your references. In those references, I think I did not see NCCN guidelines.
yes, sir.
Okay.
Yes,
So there are two approaches to therapy. one says that you have done your surgery, post-operative findings are with you.
Yes.
Based on these two only, you directly go ahead with therapy. In fact, NCCN is saying only two doses, 30 millicurie and 100 millicurie upfront.
Yes.
Okay. And once you
Okay.
have done that therapy, you do a post-therapy scan and then you determine whether you need, and then you do follow-up. Okay.
Yes.
There are advantages and as well as disadvantages with this approach. Advantages, hypothyroid patients are very symptomatic. They are very lethargic. They are unable to tolerate. So, at a shorter duration of withdrawal, you are able to do the treatment first. Second, you are bypassing the adverse effect of any stunning that is going to happen. So, your response to therapy is theoretically supposed to be better.
Okay, sir.
Disadvantage is if you have not done adequate staging, there are
Yes, sir.
chances that you have either given higher doses
Yes, sir.
or you have given insufficient dose.
Insufficient.
Okay, but
Yes.
the and invert it for the ATA process where they're asking for radioiodine scan upfront. So it is a longer duration of hypothyroid state where patient will be suffering for a longer period of time. Okay. But advantage
Yes.
is that you are able to give appropriate dose upfront because it is radiation. You don't want to either overtreat or undertreat.
Yes.
That's it. So both approaches are correct. I follow both approaches here at Patna where I am.
Yes,
So
sir.
in my intro, Dr. Vinay was very kind enough to give my associations. My another introduction is that I am doing high dose radioiodine therapy at my own center here in Patna. Okay.
Yes.
Yes, sir. Yes,
And
sir.
yeah, and I follow both approaches because see, a lot of head and neck onco surgeons they say, is it necessary? I say it is necessary as per us, but if you are not comfortable, we'll go by guidelines. Another guideline that you are following. Okay.
Yes, sir.
Yes.
Yeah.
So there was one more question, sir.
No, no, post. So okay, again, I think this question was put up by Dr. Samyata.
Yes, sir.
So, so ma'am, therapy in this case is radioiodine therapy and not surgery. So post-surgery thyroidectomy, you go for diagnostic scan, then you do therapy, and then you do post-therapy scan in all patients. But in ATA says in some cases you can skip diagnostic therapy. Okay, so in ATA it says you go for surgery, then you do give 30 or 100 millicurie depending on post-op findings, post-op histopathological findings, and once you have given 30 or 100